So look, we do have time, and as I said earlier, a very important part of the day is for you to ask the questions you need to ask. However, this is going to be difficult, but I want you to ask questions which are pertinent to those presentations we've had from Paul and from Andrew. And so I'm going to look to Martin and David and Sarah to wave at me frantically if the question asked is more germane to what they're going to say after morning tea. So I'm in your hands, Sarah and David and Martin. So who's got a question or a comment, please, over there? No, oh, sorry, I forgot to say something. Please stand up, wait for the mic, and then we're going to make you look good on screen.
Hi, Ali Crollig from Country SAPHN. I was just wondering whether there was any differentiation between put into the modelling between the eastern seaboard and states outside of that. Because as we know, the further you get away from the eastern seaboard, the harder it is to get people. The other part of that was recruitment. The ease or difficulty of recruitment included in the modelling as well, because that's another thing that's actually a really big issue the further you get away from the eastern seaboard.
Well, John wants to trump me on this. First of all, no, the modelling didn't. The primary modelling was the one done by Matthew and John and their team. And it was focused, as we saw in those original... It was focused on those original 6 indicators. Now, that sort of brings us down to that second point, is this focus on recruitment. And those 6 indicators are generally recognised as being ones which actually relate to GPs and their choice to recruit. However, and certainly when we were looking at the classification, we only used RA and town size, so we didn't try and look at sort of the other types of swings. I think there's been some good work, people looking at whether coastal towns differ from inland towns, just flat up. I think you don't actually have to go eastern seaboard. You can think of Burke and Lightning Ridge in New South Wales, which doesn't even get over the first half of Australia, and that's inland enough to suffer the same sort of issues you're talking about. So no, that it doesn't. I think one thing we want to keep in mind is, well, I won't say keep in mind, is that we are constantly looking at this, and we will be seeing how it travels in a few years' time and see what impacts it's had. We think it's a step up above RA for a lot of the recruitment tools. And there are the issues you mentioned, but I also sort of keep in the back of my head whenever these things start coming up is we'd also start wanting to look at a range of other measures. I looked at CIFA by MMM, but there is a question of how much, not just sort of remoteness classification, but we're starting to talk about an index of need. And an index of need would have to be using a remoteness classification, certainly, but you would want to include extra factors. And that is a much larger task. And I think, when I was talking earlier about using population models, I think that's the first step towards getting to grips with what that future index might be. So, in short, no, we did not look at those issues. The recruitment, yes, that was part of the original, but only for GPs. I did this presentation for dentists last week, and one of the things that came up there is, from talk and so forth, was that you actually needed around 5,000 people to even establish a viable dentist practice, and that sort of flows out when you look at the dental population per 100,000 people by modified Monash models. And so, in one sense, different professions will have different needs of it, and the cut points won't always be perfectly aligned. But we do think it's very important to have one common framework, and I think the 5,000, 5 to 15 and 15 to 50 actually, as we've been seeing, has that advantage of breaking population up reasonably similarly, and just spills out details in a rich picture. So does that? Yeah.
Can I just observe that if we're going back to the Monash model, either now or later today, we do have Matthew with us. So anybody who gets a question which is about the Monash as distinct from the Modified Monash, we've got Matthew in the room with us. Andrew, can I ask you maybe just to enlarge on something which you said, which I think is important and follows on from that question. The modelling for this was related to doctors, so that has something to say about how we use it for other purposes, how we might use it for other purposes, other professions. Can you comment on that?
I could try to comment on that. I'd also like to comment on a couple of other things too, if I could.
Proceed.
Okay, as well. Okay. Look, I know that for some professional groups, they might go, for some professional groups, it might be a worry that this has been developed on the basis of doctors. However, I would advise those people to look carefully at the way it was developed, because the sort of issues that related to this development of this model are issues that are often common to a whole range of professional groups. So from my perspective, I would see it as being more of a universal tool and not specifically a doctor tool. So, I mean, I'm quite comfortable with that. The other thing I'd just like to mention that I was just thinking when Paul was talking is that, I've mentioned the use of Modified Monash in program management and also in the statistical reporting side of things. Now, these are two issues that are intimately linked together. You could run a program, and if you're not looking at statistically at what's going on, is there, are things getting better? Is it working? Then you're flying blind. All you're able to do is to listen to the complaints from the constituents about not getting X, Y, and Z. Whereas with the statistical analysis, you've got both sight and sound, I guess, to get an idea of whether you're heading in the right direction. The other thing I'd like to talk about, or just very briefly mention, is an index of need. Now, Paul mentioned an index of need. It's something we've been thinking about for a long time. When you have comparisons between populations, for example, how many doctors are there per 100,000 head of population, there's no consideration taken whatsoever of the need of those people for doctoring services. So there are many areas in rural remote Australia that we know of where the need is substantially greater than it is in major cities based on the degree of illness in those areas. And there's certain subpopulations in those areas who have special needs. But still, when we compare, we're still comparing across the population as if everybody had the same need. Now, it's difficult to create an index of need, but it's certainly a worthy goal.
Thanks, Andrew. Another question, please. Please stand up so Hector can get a lovely shot of you and use the microphone. So hands up. Who'd like the mic? I'd love up there. Yeah. Thanks, Janine. Name, rank, and number. Thank you, please.
Hello, I'm Sharon Cosmina from Rural Health Workforce Australia. I've been around a little while and remember previous indexes that had population components, and one of the things that I actually had trouble with as time went on was creeps between brackets when towns or locations either lose populations or gain populations, and this can become an issue if you're giving out incentives. And so I'm just wondering, in terms of the department's view on the maintenance of this, how often it'll be reviewed, and how, moving forward, some of these issues might be dealt with.
Thanks, Sharon.
Well, fortunately, we put a lot of thought into this. In our original design and in the formal papers around Modified Monash, it notes that it will be updated after every update of the ABS's remoteness areas classification. The remoteness area classification follows up generally after a census, but it's certainly a consideration of also what the UCL boundaries are. And normally the process, as far as I understand, is the ABS provides that information to JISCA, APMRC, I think they are, or I forget what exactly the label is, who then do the ARIA plus index. And we then, as we did when we originally created this first version of the Modified Monash, is we go back to them and ask them for those road distance buffers they use for the ARIA plus index, and so that we're using the same sort of measures in this one that went into the RA to try and make sure there's some internal consistency. So I will say that there's every intent, and as formal as we can possibly make it, that it will be updated after every remoteness area update. Albeit I think all these things take a little bit of time as each step goes through. But we're also concerned with the RA. We did have a lot of feedback pretty quickly after we introduced it, but we hadn't kept in mind the need for some sort of review process. And so it took us about 3-4 years before it got to Senate inquiry. It took us another 2-3 years after that before we had a Modified Monash come out. And now it has to feed into programs. So it's going to be a few more years as it's taken up across the department where they see a need for it. So with that in mind is that we already sort of have a work plan towards taking a look at the Modified Monash in terms of just how the parameters work. Things that we want to sort of go out to consultation when we do that, and it's still sort of, we're going to see as it's been in place over time exactly what issues we want to look at. But you'd be thinking about things like are the buffers right, are the town points right, given the way that it affects where doctors go to, or all health professionals go to. We're very focused on how this might affect everybody. And so that's certainly on the lines, but I will say that we will broadly and clearly indicate any change to those parameters well before they take effect, because ultimately doctors need to plan, and everyone needs to plan what their future looks like when they're setting up a new business. And we don't want a situation where doctor sort of goes one place to get an incentive and then we turn around the next week and completely change that. So that's the other concern we have when we talk about making changes to it, and one reason why we are pretty firm in saying that we will keep the remoteness, the formal updates will be after each remoteness area classification.
Thanks, Paul. Dennis.
Hi, my name is Dennis Gitter, I'm a rural disability consultant. Andrew, you mentioned the warning or the suggestion that for those professions to not see it as just specifically a doctor-focused one. But just thinking also about other systems. I'm particularly thinking about the disability, the rollout of the disability NDIS, which is adopting this classification too. Has there been much work done in terms of the applicability of the scheme in other systems apart from just solely other professions in the health system?
I'm not sure I can answer that question. I'm not sure I know enough.
Okay,
I'm aware that National Disability Insurance Agency has at least done some work with it. Are you aware, Paul, of any?
Is the NDIA in the room? They are. Own up now. Come on. Give that man a microphone. So seriously, thanks for coming. We do know that in the rural and remote work that it's doing, the NDIA has adopted or is moving to adopt so perhaps we can hear a little more. Thanks.
Yeah, so that's right. So the agency's developed its rural and remote servicing strategy, and it was actually just endorsed by the Disability Reform Council on November. So it's not yet public, as to be published, because it's still got to go through COAG. But the MMM model was what we recommended to use, and it's been endorsed. So that's what we will be using for rural and remote.
Thanks. Do you want to retrospectively tell us your name so we can...
Oh, sorry, Stephen Brecht, and from in the full scheme transition.
Thanks, Stephen.
Gordon?
Janine over here.
Gordon,
yes,
can I
Andrew, go.
just with Sharon's question previously, I think were you referring to RRMA particularly? Yeah, and I just thought it was something that might assist with that, and that is that RRMA was largely, it was sort of like parentless really. I mean, it had parents, but then the parents abandoned it to an extent, and so, but we have very good parents in both the ABS, and there's this sort of relationship between the ABS and the department to look after. And I think that's a lesson well learnt, that RMA was really good in that it took into consideration town size, and then it had to be abandoned because of the fact it became out of date so very rapidly. So, anyway, just to
A little bit from the department's point of view on that. There was, after the RAMA came in, it was built on the tools we had available at the time, and it was a health department product. And in fact, one of the initial uses of ARIA, the very first ARIA index, was the first attempt at looking at that tool. And we contracted with JISCA to actually develop it, and then they developed into ARIA Plus and worked with the ABS in turning it into a remoteness category. And the problem with RAMA was twofold. One was that it, at the points when it was being updated, we started looking at other classification systems, because with more technology we had a better approach forward. And then in 2008, when we said, that's it, we're going to all swap to RA, the outcry was so loud that any halt in that direction was stopped. So my personal mission in life is to remove RAMA from everything. And I don't know how successful I'll be. But again, this is why we're doing the 3-year review of the Modified Monash. It's to make sure that if new technologies come available and we get a better way of looking at Australia, that we take that up immediately rather than letting this geographical classification stay around unupdated but still being used.
Now we're really getting down to when we hear about persons' personal missions in life. This is good. I think the microphone is with this person.
Greg Mundy from Rural Health Workforce Australia. This is, I think, my second iteration of living through a change in geographic classification systems. I remember people in the health department in Victoria pointing out moving from A to B, and now we're going from B to C. One of the things I find useful to keep in mind when thinking about them is that geographic classification systems are extremely valuable tools, but they can only tell you so much. And sometimes when you try and overuse them for purposes which they can never satisfy, that's when people say, oh, we need to change the geographic classification system again, whereas in fact, in my experience, what you might have to do is change the way in which you use it for particular purposes. And I'll finish up quickly. One of the points that Paul made about different primary healthcare professions is a good illustration of that, because the scale at which particular types of primary healthcare professions is viable will actually vary according to their business models, and capturing business models is several bridges too far for a geographic classification system. But if you have a standard ruler, you can then choose how you use it to measure your particular activity.
Thanks, Greg. Would you pass the microphone along? Last one, I'm afraid, just in here. Name, rank and number, if you wouldn't mind.
My name is Mo Mahan from Australian Medical Association. Question to Paul. In terms of implementation to other programs, is the department planning to introduce MM to PIP, Practice Incentive Program? If it is there going to be any modeling done? Because I would expect that implementation of such modeling to PIP will impact on a lot of practices on outdoor and regional areas. Thank you.
So can I get you to repeat the program you're talking about?
PIP, Practice Incentive Program.
Practice, yes. Which is still relies on RAMA for its rule loading. It is definitely out of my province, and this is one of the things that often happens in government departments. Different areas own different programs, and they know the policy objectives of those programs. And the Modified Monash suits a lot of purposes, but not necessarily all purposes. So I'm not aware of any PIP changes, and nor would I be if anything was happening. And again, there's some Medicare billing items which are based on RAMA still. And if those changed again, I would not be made aware of it. What I can say is that in the actual area, they do have some excellent modelers. And I have no doubt that, and especially it's been a driving force in the department since the new secretary came in. Always there beforehand, the idea of evidence-based policy, but he is very much interested in strengthening health's information network and strengthening and justifying the actions that are taken, or at least understanding them. So while I can't speak to the PIP in particular, I have very good reasons to believe that there will be a very thorough analysis, because we do know where all the practices are, we do know how much everyone's getting, and we do know the patients that are going through those practices. So it's at least one of those places where we're not as limited around our knowledge of the health landscape as other areas. So yeah, if I can give you any comfort in that, I do think it will be looked at thoroughly.
Thanks. So that's an important question where we need to watch this space, as it were. We're here for today for a short time, not a good time, so I'm going to ask you to come back with your tea or coffee in 10 minutes, literally, so we can make full use of the time. Can I ask you please to thank Paul and Andrew?